So just calling everyone to order, please, and can I welcome you to our Health and Community Services Board meeting. At our last meeting, we decided to move from a monthly meeting to a quarterly meeting. So we haven't met for 3 months. This is the first of the quarterly meetings. There's, as you can see from the agenda, there's a lot of meaty stuff to discuss. First of all, we'll start, if we may, with introductions. So I'll give my name and title, and then I'll go to my left, and if we can move round the room to the top, and then come over to the top here, and come back to meet. Okay, so I'm Deputy Richard Brennan, Minister for Health and Social Services.
I'm Caroline Langdon, Director General for Health and Community Services.
Rose Naylor, Chief Nurse, Health and Community Services.
I'm Trevor Poynton, I'm Deputy for St John, and I'm an Assistant Health Minister.
I'm Fiona Brennan, the Chief Executive Officer of Brighter Futures Child and Family Charity.
Hugh Raymond, Assistant Minister for HCS.
Michelle Walsh, Head of Finance for HCS.
Jo Close, Associate Director for Improvement and Innovation, HCS.
Emily Edwards, Head of Informatics for HCS.
Danielle Colbert, Secretary.
Mark Richardson, Ministerial Support.
Agent Noon, Medical Director of Primary Care.
Steve Graham, Associate Director of People for HCS.
Rose Naylor, Chief Executive of HCS and September.
Paul Current, CEO for FNHC.
Louise Ogilvie, Manager of Mind, Jersey, Family Care and Peer Support Service.
Gail Cadell, Director of Clinical Strategy, Jersey Hospice.
Mike Wolferman, Chief Executive of Jersey Hospice as of 3 weeks ago.
Henry Vickers, Project Manager at HCS.
Patrick Armstrong, Medical Director for HCS.
Okay, could I ask our Board Secretary to read the apologies, please?
Apologies from Robert Sainsbury, Anushka Miller. We've got Martin White, Patricia County, Maggie Gill, Emma O'Connor, Claudine Snape, Ruth Hampton, and Nicola DeJesus.
Okay, now just to tell everybody that the meeting is being filmed because this is a public meeting, and in normal times pre-COVID we'd have members of the public in, but we're filming it so that it will be available. It occurs to me that when we're speaking we should probably remove our masks because there may be some people who will want to lip read. Is that in order? The medics here, if you move masks, or am I breaking any of the regulations I've made? I think we should. It'd be clearer for people if we can, unless you wish to keep your mask on, but it might be helpful for people to remove your mask when we're speaking. And can we try and project our voice also? Because I'm not sure what, if any mics we've got. If we can try and be clear when we're speaking. Can I give a special welcome to those who haven't been in an HCS board before? And that would be to Mike Palfreman of Hospice, to Rosemary Finlay of Family Nursing and Home Care, and Louise Ogilvie from Mind, Jersey. So you're especially welcome today. Thank you, and please feel free to participate fully, get into the swing of things. But Fiona Brennan, I think you've come before, is that right?
I came to the last meeting.
Yes, that's right. You were long-standing member of Brighter Futures, very valuable. Yes, I think that's all welcome. As a formality, we ask anyone if they have declarations of interest to make in connection with any of the business we're going to discuss. Can you please say so now? I take it there are none. We have to we seek approval of the minutes of the previous meeting, which are in your packs. They consist of 11 pages, and what I will do, I will call out page 1 of 11, etc. And if you have any comments, can you please halt me and tell me what you wish to say. So, page 1 of 11, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10, and a very short page 11. So therefore, those minutes are approved. We move on to item 4 of the agenda, the matters arising in the action tracker. Who is able to take us through these items? Gosh, it's small print. What have we got on the top here? 12th. This is outstanding from the 12th of October 2020. We will request a review of speech and language therapy. Can someone give us an update on that?
Yes, Minister. So we had a review. This particularly related to Pediatric speech and language therapy, and a review was done earlier this year, and a paper came to the Quality and Risk Committee at the end of April, which basically showed the impact of the pandemic on our waiting times in this area, and the plans to address some of these long waits. So I have included detail of it in my Quality and Risk report, which is taken from the paper, and can give an update in that section if that's okay. So they have done a service review. They are due to come back to Quality and Risk next month with an update on their recovery plan, but they are showing progress against some of our long waits, which I can go to in a bit more detail later.
Okay, so let's discuss that when we give your report later, Rose. Thank you. And then the other item was linking with family nursing to give support about getting the teams in. Has that been able to be progressed?
It's been progressing a little bit, it's not been resolved yet. We've still got issues with teams 365, including licences, so there still needs to be further work on that to be completed before the contract, the new contract.
Right. Okay, is there any time scale for completing that?
No, I haven't been given anything since our original meeting, Jeff 10th. But this does need to be progressed.
Okay, we'll leave it open, and we'll sit with, trust it will progress. Chase whoever you need to from them.
I think it will. I think if we can progress it to the contract negotiations, Joe, that'd be really helpful. I think we should leave it on the go.
Yes, please. Let's keep it open. And, yeah, the first item on speech and language, Rose. If you're dealing with it through your committee, presumably we don't need to keep it on our action tracker. You'd escalate it to board if need be.
Yeah,
right. So we should remove it from our action tracker. Okay. So our next item is the integrated performance report. And I'm pleased to have this on our agenda because it has generated some publicity in recent weeks, as we all will know. And I just want to say a few words, because this will become a regular item on our agendas. Each board we will review our performance, which is an important thing to do, and that's what we have always wanted to do at this board meeting. And it reminded me that at our first ever meeting of this board, I spoke about its purposes, which included seeking assurance about the standards and the performance of services provided by health and community services. I said then the board's role was to hold HCS to account for the ambition of Health and Community Services to create a healthy island with safe, high-quality, affordable care that is accessible when and where our service users need it. I said then the board would provide visible leadership to inform and create a greater understanding of the services provided by HCS and all other health and care providers as well. An understanding of what we are striving to achieve as providers and the risks we face. I said I wanted the board to create a culture of openness and candour and instill an eagerness to learn and to improve. Now, that first meeting was a couple of years ago, but we've made good progress, and I really want to thank all those who contributed to the board. But with this report we're going to look at today, we're taking a huge and significant step forward. If approved, it will be published, and for the first time in Jersey, members of the public will see how we monitor quality and performance across HCS, where the stresses and strains are, because they're always there, and members of the public will be able to hear about our plans to overcome difficulties and improve performance. So I want to thank everyone who's contributed in ensuring that the collection and reliability of the data that goes into this report. And this demonstrates a culture change in HCS since I came into office, as the organisation is now collecting so much more information to measure the quality and responsiveness of our services, and to provide information to everyone using those services. We must always remember HCS is a large, complex organisation with a very wide scope of services. So at any one time, like any large organisation, parts of it will come under pressure and will struggle to maintain the high standards of care used to measure quality and performance. So some indicators in the performance report will show as amber or red, but that need not create alarm around failing services. Rather, it will show that we openly and transparently highlight the pressures faced by those services. And those pressures might be due to internal factors or external factors. And that will allow the board to be assured and to investigate the reasons for those pressures and to understand that they are being managed and reduced. So when people do see our indicators marked red, and there will always be some, I'm sure, because that's the nature of organisations and the conflicting pressures in HCS. I hope they will reflect and not be surprised that running any health and care service poses huge challenges. I hope they'll concentrate their attention on the steps we're taking to meet those challenges, and how what I said at that first meeting of the board is now demonstrably in place, that we're creating a culture of openness and candour and instilling an eagerness to learn and to improve. So thank you for allowing me to say that, and I want to pass over first to the Director General to introduce the report, and then we'll go on to the detail. Thank you.
Thank you, Minister. So this is our quality and performance report, which we have been sharing with the board since the board's inception in 2019. And thank you to the board and the respective assurance committees with helping us with the development of this report and the indicators that will demonstrate how we deliver care for our patients on the island. There are various indicators within the report, which, as you know, we've been working through for the past 2 years. And whilst the data quality now, I think, is probably the best it's ever been, we will always have ongoing data quality issues within HCS because we do have a mixture of paper and computerised systems, which just causes some challenges. So I'm going to ask Hilary, who works for our Group Managing Director, Rob Sainsbury, to take us through some of the highlights of the report and also to raise for the board some of the areas where perhaps we have some issues and what we're doing to resolve those.
Thank you, Caroline. I think it's important to stress, as Rob has led with in the report, there are a significant number of areas where we have demonstrated improvement in our services in performance up until the end of June 2021. They are detailed on the first page, but significant improvement within maternity services in terms of the 30-degree tears and an average length of stay improvement on the maternity ward, spanning across to dental and across the full spectrum, which is kind of laid out on the first page for you to review. I think it's important, if, as Caroline has referenced, while this does highlight areas of good performance, if I can pull out the areas where we are still challenged within our services. So if we start with the emergency care pathway, attendances within the emergency department, and I can see a minor typo in the report, which I'll amend with the team after this.
Hilary, could you just tell us what page we're on?
Sorry, I'm on page 3. Apologies, cantering through.
Actually, that's the overall page 21.
Yes,
Yeah.
the executive summary, yes. So, attendances within the emergency department are increasing, again in line with pre-pandemic activity. We have been challenged in month again with our 15-minute to triage performance, and also with a number of long stays within the department, which is often linked to onward care external to HCS settings. The team are working away, looking at improvement programs within and looking at how they can adapt their staffing model, particularly to ensure we are having that first 15-minute assessment of our patients when they attend the emergency department. In terms of the winter plan for the care group, this is in development, and we're anticipating first drafts to be completed in September, which will obviously give assurance going into the winter period coming forward. If we move on to scheduled care, a lot of work has continued to take place within the scheduled care services, looking at our outpatients and our elective admissions activity. We are challenged, as Caroline has referenced, in terms of our data quality, and the care groups are highlighting areas where we can make amends and correct our waiting list to properly correct what is included in there. Areas to particularly highlight to yourselves, I think, within outpatients would be ophthalmology, and we are also challenged within dental services as well. Both ophthalmology and dental services have executive-led task and finish groups, which are developing robust improvement plans for each of those areas, and ophthalmology in particular will be coming to fruition, I think, in September, which I can reference later on in the discussion if you wish. In terms of our elective admitted patients, we are challenged in terms of our waiting list. We are aware that 80% of our patients come from 4 specialties on our services. 2 of those programs have, again, executive-led task and finish programs in place where we are looking to address swiftly and effectively and safely our waiting times and maximise our throughput over the coming months. Again, one of those is ophthalmology, and again I can reference what we're doing shortly as we kind of go through the report. In terms of maternity, you'll be able to see from our activity and the narrative that it has been busier in the first half of 2021 than we were in 2020. Again, lots of work is happening within that department to look at what can be done to bring their elective sections or C-section rates in line with best practice, and what kind of fits the cohort that we have within Jersey. And any questions I think maternity raises is fully briefed to be able to respond clinically, much better than I can on that. And in terms of mental health, again, you'll be able to see we are challenged in this area in particular. We have a lot of activity going through at the moment, and you'll be aware of the kind of complex recruitment and challenges that we face in there. Is there anything particular that anyone would like to ask any questions about?
So around ED time to triage around ED time to triage. My understanding is though is that some of that is to do with COVID presentations.
Yes.
Yeah.
It is. It's COVID presentations, and also it's an adaptation that they've made to the model slightly within the department. On review with the ED team, it has been highlighted that again we have some reporting issues within there, so we think we are understating our performance rather than overstating our performance, and Beverly's team are working closely with the general manager for medical division to ensure that we have that kind of data actually accurate going forward.
What are we looking at when you're asking that
Time
question?
to triage.
What page? What?
Hilary, do you want to what page?
So we are on overall page 30 of 84, and it's the table starting with ambulance in the left-hand column. It's the first metric that appears red and has is stating it has 67.2%
Yes.
in March.
So, Adrian, I covered for Rob during the beginning of the third wave, and I was quite hands-on that week. And I just want to pay tribute to ED colleagues, because the dedication they put in through the sheer volume of potential COVID patients coming through the front door, and how they manage those patients by not inappropriately admitting them and putting those patients at greater risk was outstanding, because we had significant preservations in those first few weeks. So I think that may have an impact around triage.
Yes.
Okay, and then the winter plan. Now I know that winter planning is quite a new thing for us, but this year are we inching or edging towards system-wide planning, or is it just HCS winter planning?
So I think James's ambition is system-wide planning. We'll be having broader conversations, but I would look to Patrick and Rose to highlight some of the discussions that are taking place within the group.
So I think that's something for the floor to maybe to think about. I'm looking at hospice and family nursing and brighter futures of mind around how we system. HCS as well, we perhaps worked in silos, so I think there's something about that going forward.
I think Bronze Group is ideally placed to kind of support with that actually, because they've really kind of knitted together really well. I think you sit on that, don't you?
Yes, I do.
Yeah. They've really kind of come together really well as a group and kind of function well as a group, so I think they could, support with that actually. I'm also hoping that the 24-hour nursing, community nursing service that we start, as that progresses and we take more groups of patients and that's developed, that will have an impact going forward over winter pressure.
And finally for me, and can I just clarify here, the mental health pressures around waiting times.
Can we look at the page and metric?
Can you just
So
highlight?
mental health is on page 31 of 84.
My understanding is that's predominantly CAMS,
Yes,
because my understanding is that we've addressed the challenges around adult mental health
Yes.
waiting times.
Yes, predominantly CAMS. And from discussion with Beverly today, we're anticipating being able to have our PTL established for mental health October.
That's fantastic, because I know we've been waiting and asking for that as a board for a long time, so that's really great news. Thank you. Thank you, Lisa.
So what does that mean? That the CAMS metrics will be
So it means
looked at separately?
So it means that we'll have a PTL for adult mental health.
Patient tracker.
Yeah, okay. My understanding is that CAMS are looking to do something similar. I don't know if that's a point that might be better informed.
As we stand, we're trying to align various monitoring methods between the two services to improve the cooperation.
Okay. But on that page I see that in June we suddenly shot to four children under 18 being in the adult acute admissions. That was in June. I hope we've managed to bring that down by now.
My understanding, Minister, is that there is currently one individual remaining in all of the counts.
Yeah.
Inappropriately, really.
Yeah.
There is no alternative facility.
Yeah, I know it's not far from ideal.
It's an ongoing challenge.
It represents, or it may represent COVID pressures, because I I know some young people are being affected very significantly by the continued uncertainty that COVID creates. Can I ask, overall page 29 of 84, outpatients, the percentage of patients waiting more than 90 days for their first appointment. Well, that was high during the peak of COVID. We see it coming down, but it's still at 40% in June. And what's the standard there? What are we trying to get to? It's just I can't read the last grey box, I'm afraid. It must be lower than 40%. It must be lower than the 30s.
Yes, I believe it is. Yeah.
So anything over 35% is red, and anything under 25 is green.
Okay.
One of the challenges we have with outpatients still is that we're still having to have social distancing with our outpatients, which limits the amount of patients that we're able to see in each clinic. We are working through alternative scenarios with that, with infection prevention control, around how we can start to bring more people into outpatients, but we still have to be very careful around infection. There is also validation issues, is my understanding, Kelly. I don't know if you wish to elaborate.
Yes, so Rob has done significant work to enhance our kind of PTL review and scrutiny that's taking place by the clinical care groups. Over the past month, we have identified a fairly sizable amount of validation issues on the PTL where episodes aren't being closed down. So we feel this is overstated. Beverly and I are regrouping about that this week to see what we can do to quickly rectify where our kind of challenges are, but also ensure that we're providing the correct data to our clinicians. This has been a clinically led process so far in two of our challenged areas. So the consultants have been supporting, or with the support of their assistant general managers, been reviewing their pathways and highlighting these challenges themselves. So it's emphasising the ownership and collaboration process between our teams.
Okay, so the data being improved all the time. But
Yeah.
just remembering that members of the public might be listening in, we referred to PTL. Can we describe what that is?
So PTL is a patient tracking list. It looks to capture all of our details of the patients who are waiting on the system, but split by specialty, by how long they've been waiting for, and also through clinical urgency. I think if I could just jump in to comment on one section, provide some more detail. Through the process that the weekly review meetings that we have in relation to outpatients, one of the first questions that we go through with the care groups is ensuring that urgents and soons are dated. So we are, the clinical order, we don't have patients waiting over 90 days that need to be seen and treated quickly by our clinical teams. So I can give you some assurance around that process.
Yeah, I understand. We've spoken about ED, emergency department. See, in the emergency department, there's the average times people spend there seems to be good, but at the extreme end, we're red throughout the year on the total numbers being there for more than 10 hours. Is there a reason why that might be?
So, through discussion with again the team, we're marginally overstating those numbers within the data. However, it's often when they're waiting for an onward pathway which is outside of the control of HCS. And they will come in overnight, typically, that they then get picked up in the morning. I don't know if
There's a lot of patients, I think it's COVID as well, so we've had a lot of patients in the department, which I think I alluded to earlier. ED will keep in the department, they will assess, they will and to see if they can turn those patients around, because the mentality is let's not admit patients to hospital if we don't need to. If you look at their metrics across the board, you can see how they've been impacted by COVID all through the year, but their conversion conversion rate is still incredibly impressive if you compare that to UK conversion rates. They had problems in December and January, but again, that's when we were incredibly challenged around COVID. But
And
again,
can you explain the conversion rate?
so that's the amount of people that ED admit to hospital.
Right.
So if you see with excellent performance around that, excellent performance around average length of stay. If you look across the whole performance report, you can see how predominantly our reds are impacted by COVID. But I would ask colleagues to challenge us around the reds that are continuously red that have nothing to do with COVID. And I recognise having this report at your fingertips now, when you previously just had it on the screen, will enable you to start challenging us. So one of the metrics I would want to challenge on, if I was external to the organisation, is the percentage of deliveries by C-section. That has been red all the way through since June 20 and continues to be red. So one of the challenges is what are we doing in the organisation around that? But I think as an overall performance report, most of our reds are because of the impact of COVID. But some of our quality indicators are ones that really need some work on, and I know the chief nurse is leading a lot of that work, as is the medical director.
Okay, so taking up Caroline's prompting, would anyone else like to ask any questions, particularly out of partner organisations?
I'm just interested in the older adult acute bed rate in June of this year. It's very high.
Yes, so that's on overall page 31,
Yeah,
is that right?
31 is full.
And that's the second metric, is it?
Yes, the bottom, yeah, second metric. Brilliant.
Oh, the second from the bottom, do you mean?
Yeah.
Sorry, beg your pardon, yes.
Older adult acute bed occupancy in June 96.1% in June. I just
Yes.
was interested in the context of it.
Good question.
Rose, Patrick, you want to shed any light on that? I know, I'm conscious we don't have Isabel or Rob with us today, who are closer to that portfolio.
So just in terms of the bed occupancy, I mean, I think right across mental health we've seen a real fluctuation in bed occupancy. So overall they're trying to manage the total inpatient provision as almost like a one service. So they're not specific with different wards in the way that they used to be. I think that just represents some of the pressures that we have seen because of COVID. But in relation to the whole service at the moment, they are challenged with their bed occupancy. Again, I haven't got a rationale to say why it particularly spiked at that period in time. Except to say you'll see across the whole year it does significantly fluctuate, but we do try to run our bed occupancies at around 85% as much as possible. But there is regular meetings in terms of patient flow, support across the whole system, and how we support people in the wider community as well. I mean, I haven't got any more detail than that today.
That's great.
We can get more information on that for you. Rob and Isabel, who are better briefed, will be at the next board. We can get it before it to be helpful.
Yeah, can we do that? Can we circulate
Yeah, absolutely.
all attendees with summary position?
Could I ask, in terms of the ED data that you collate, it would be really good if we could interrogate those, if you like, people who don't need to stay in and why they don't need to stay in. How many of those patients are frail elderly? How many of those patients are end of life? So that gives us in the community some sort of insight into kind of what we're dealing with.
I think that's really useful because one of the metrics that I've actually just leapt out at me is that is our rate of emergency readmission, which is quite high across the board, which is the last metric on page 30 of 84. But if you look at our percentage of discharges before midday, that's really low, and our occupancy is really low. So it suggests that we're not discharging people early. So why are we readmitting them? And is it to do with lack of provision external to our walls? or is it an issue around discharge, or is it a linking up with discharge with GPs and community provision? Anyway, can we have a look at that?
Yeah,
Can we try and understand that? I don't know.
It would be really nice to kind of almost have a group to kind of look at almost this report and think actually what we need to interrogate and drill down a bit on, because I think there's some really key questions here.
I think that really suggests there might be a gap beyond our walls that perhaps we could work together to address. Thank you.
It would be an opportunity to overlay data on just thinking sort of discharge, especially the rapid response and like we can overlay some of our data to actually work out if there's anything further we can do as a community to bring people out as a community.
It will be useful because trying to ensure that people are equipped to live independently at home, deal with the conditions they have, and not have to be readmitted. That's what it's all about, isn't it? Yeah.
Well, it's about things. It's almost links into the emergency missions as well as making the community prevent people actually hitting that's not missions, but prevent them actually hitting it. Is anything we could put in the community?
If they had what they needed at home, then they wouldn't need to transit.
Although the conversion rate suggests that we're only admitting real sickies, so there is also the question about, there's a question on the other end, but there's a question about what we're doing in our wards to prepare for discharge.
I do actually think, and it's not from this report, but just from, I think there's a big piece of work to really look at discharge, you know, and how we really get it right for both patients and providers. You know, if we do it right, patient will be sustained at home, and it will stop this bounce back and the distress around that. And you know, it's really difficult to kind of quantify if you don't feel safe in that discharge. That's what's going to happen. And the impact of that on patient and family is enormous.
Maybe Joe that could maybe relate to the innovation improvement.
Yes, can we take those comments and try and get a greater understanding of what this is showing by our next call? Liaise with hospice, family nursing, everyone concerned. Are there any questions from anyone else? Please. That's what the report is here for, to highlight issues and
Can I just mention about the tooth extractions? It's a very interesting statistic here that we're hitting year to date 39 when we're looking to target 25. So there's a lot of youngsters who are having a tooth extracted with a bit of infection going on. That would be reduced significantly.
yes, sorry, where's that metric?
Sorry,
The Children's Health. That's
yeah,
right.
Children's Health, page 28 of the report.
So I'll ask Patrick to say something about plans for dentistry.
I think that's, you're quite right, it's a reflection on the work we need to do around prevention. The reason for all these extractions are children presenting very late, children who often haven't had access to good dental care through their lives. It's really a sort of point of crisis in terms of their they'll come when they're in pain and the tooth is beyond salvage. I think the more piece of work the Minister's asked us to do about dental services across the whole system, not just what happens in the hospital, will be key to that. And making sure children get access to dental treatment from when they're born. That's something that we are looking at, how that would be provided, and I know the Minister is very supportive on that, but will require significant investment, I suspect.
It's an ambition of the whole government in our government plan also. We do want to improve things for children's dental care.
At the moment, a lot of that dental care for those children is only provided through the hospital, but a lot of that should be provided within the community. We have a community dental service within a hospital setting, which is obviously contradictory. So we need to find a way of getting those children seen and treated. I mean, children should be seen within the first 6 months of being born to have their first bit of advice for dental care. That's the aspiration. That's where we hope to get to, but it's quite far removed from where we are now.
But we've got to begin the steps.
We do.
Any other questions from anybody at all? Thank you everyone for the questions you've asked. Can we therefore agree that the integrated performance report is accepted for publication? Any against? Then we accept it for publication. Thank you. Moving on to item 6, we have one of our committee reports, the Operations Performance and Finance Assurance Committee. So can I ask Jo Point, who's our Associate Director of Improvement and Innovation, to present, please, Jo.
Thank you. So, as the Minister said, our Operations Performance and Finance Committee have met with our Chair, in Raymond, 4 times since we last met. We feel confident now that we've got a good governance approach in place with a detailed work plan for the year. We've got key indicators that are provided and discussed at each meeting with in-depth presentations as through the work plan. We believe good assurance has been given to the group around the areas discussed. We've had presentations on the portfolio of change and provided assurance to the leadership team around all the change projects, including the progress on the Jersey Care model implementation. We've had a presentation on emergency planning and resilience, providing details of the recent baseline assessment, review undertaken around preparedness and resilience for the future. There are 68 core standards, 64 of which are applicable to us here in Jersey. In the absence of the statutory legislation in Jersey, we've set out a baseline has been carried out and that we've checked against that. We've also had a report on the digital programme. That was provided in June with an overview of the programme and assurance of progress. The major item on there is the electronic patient record, which is progressing well. And we've had very good progress against the Controller and Auditor General and scrutiny recommendations throughout the first quarter. I won't talk to finance because we have a finance report coming later, which is much more detailed than the notes on this report. And you've just heard the performance report, so I don't need to report on that again. You've had questions there. Risks have been reported through the Care Group Performance Review, and they are passed through to the Risk Committee. And that's the report for this last quarter.
Thank you, Jo. I'm interested in what is called emergency planning and resilience. So is that purely something that's arisen out of COVID, or is it far wider than COVID? What emergencies are being covered by that?
So currently you're correct, it's mainly COVID is the main topic, but no, emergency planning and resilience is preparedness for any emergency that may occur on the island and making sure we're prepared for that. So historically, without having a pandemic, other things that may occur and make sure that we've got everybody in place if an emergency happens.
So does that include industrial accidents?
Yeah, it could do industrial accidents, it could be a boat tipping over, it's any emergency that would impact on the health and care services.
Okay, so and that's good. So who is it? Just HCS that's involved in that planning?
So it's been widened with the community resilience response that we've had for COVID at this time. There's usually a plan that Rose has been to one recently, which is wider government, sort of emergency planning across the government, and there's joint sessions and training around that, so that we're all ready as one government and as one system as required.
Hugh, I'm sorry, I didn't give you an opportunity to introduce yourself.
No, it's interesting because it cuts across two fields, which is a bit difficult because there's something I'd like to say later on. But just going back to what Joe was saying, I don't know if you remember about 3 years ago we had where the boat crashed in the harbour and everybody got together from the Army, Police, Health, everybody. It's those sort of things that we have. A plane crash is always the one that comes up with any discussion that we have, and that Joe's team is putting that together if any disaster does happen, and that's really what we've been looking for. The problem is we just don't know what's around the corner, Chairman, and therefore we have to put it into the system, which does cause a certain amount of effect on the finances because it has to be in there just in case something does happen. And the other thing is, which I'm learning very rapidly, of course, it affects the bed situation in the hospital if people are injured. So it's a much wider thing, and I think as a group we must make sure that we are there ready for a disaster to happen. Touch wood, we've never had one, but you never know what's around the corner.
Good, it's right to plan. Any other questions from anybody? Yes.
Can I ask Joe about, because I noticed on the IPR that the complaints are still not great. How's the work going on, the innovation work around PALS, around having a more responsive service for our patients and their complaints?
So a review has been undertaken, that's been carried out, that review's been passed over to Rose and her team to look at the recommendations. There's further work we were just discussing last week that we want to do looking at those recommendations to make sure that our PALS, our complaints, all our services come together to be as responsive as possible. And there's also a piece of work that we're doing across government around the customer strategy, and we're compiling our part of that in line with the review and recommendations that come from. But that hasn't been published, it's still for reviewing the review, and they haven't checked the review.
And are we involving patients? Is our intention, because I know from my mailbox, I know the Minister has the same, that patients find us sluggish in our response and indeed not responsive. Is the intention that we involve patients in the formation of that service and how we respond to them?
Yes, absolutely. So the whole of the improvement and innovation team have done a piece of awareness around co-production and co-design and how we do that. So every piece of work that we do in one starts with the patient or the resident or the customer, so from a different perspective, so absolutely.
And then that data around complaints is monitored through quality and safety?
Yeah, quality and risk.
Thank you for raising that. It's an important issue. Any other questions? So we're asked to note the report. If the board members happy, we note that report. Okay, duly noted. So then we come on to item 7, that part of our meeting in which we ask our partner organisations to give us a brief update on what's happening in their neck of the woods, and how we might help them, how we might coordinate our efforts for islanders. So there isn't a list here. Would somebody like to kick off?
I don't know.
Thank you.
So for my Jersey, we have in lockdown, Tricia did a bit of research, and so we've rolled out peer support for older adults, so people over 65, but also a recent perinatal peer support service for parents of children under 5, so that was on ITV last week. Family and carer service that I manage, we're also going into each department to look at the triangle of care, so working with older adults and adult mental health to keep the triangle of care, so that's working alongside families, so not just seeing the patient, but the family and carers. And then in October the 8th, we're having a Reconnecting with Hope conference in partnership with Jersey Recovery College. So that would be people who access our service who've got lived experience of mental health presenting, and then alongside the government will be asking questions in the afternoon about how we can improve services working together. Can't remember what it is, I think it's at the Royal Hotel.
Okay. It's all about working together, isn't it? So important to coordinate efforts. So.
The other thing I've just remembered is that I meet monthly with adult mental health services and also older adult mental health services. Sharon Henson is also just agreed to meet with me monthly, just to carry on the discussions around child care, family and carers, but also about risk and complexity of cases. So I'm really pleased to have that communication.
That's good. It's good to hear. Thank you for meeting them. Bronwyn, would you like to go next?
Yes, thank you. We're currently obviously in a transition period with Untitled Rotaries come to FNHC. This will be my last board Rotary takes over from the 27th of September as CEO. We've done a review on our 5-year strategy. So our strategy ran from 2019 to 2023. We delivered about 85% currently. So one of Rotary's ambitions is to look at our strategy going forward. We are busy building the 24-hour community nursing offer. So we started the service from the 1st of April, and that's building. We've had very positive relationships and working with JDoc, and we will be extending that more comprehensively with the hospice and our district nursing and rapid response services. We'll be extending referrals in and out of them. We've started that work already. The reason that we haven't sort of extended that sooner is the recruitment, and I think this is worthy of note. So we've gone out for 2.8 full-time equivalent advanced clinical nurse practitioners in the UK and on Ireland. We've successfully recruited 2, but the 0.8 we are struggling with, which has been quite a surprise to me, because I thought being an advanced clinical nurse practitioner, having that career pathway would have actually attracted a lot more interest than we've actually had. So I think it's something to note, especially with the work we're going to be doing on the workforce plan as well. It's quite interesting because it's a fairly senior grade, it's a really good career pathway, so it's been quite interesting response on that. We're currently working with Jo and her team on the Jersey care model in terms of the commissioning strategy and intermediate care strategy. And one of the things we would like to work on in family nursing in the latter part of this year is really more around service engagement and service user feedback. So we're working on a framework of how we might do that across the system in terms of community services and actually feeding into the Jersey care model. So that will be a bit of work that forms out once I think we've got the commissioning strategy and once we've got some work with intermediate care, how we actually engage with service users more and get more feedback and work with them to widen participation.
Okay, thank you. Does anyone have any questions for family nursing or indeed Mind Jersey, I should have asked before?
I think, Bronwyn, it would be really good if we could almost join up in terms of the service user feedback stuff so that we get feedback around the whole of community services rather than being kind of just about FNHC.
I think that's something that would be really useful so that we can
get really robust data.
And patient experience.
Yeah,
That would be really good.
Chair, could I ask a question?
Yes, please.
Yeah, thanks, Bronwyn. I just wondered I think previously at the board you talked about some of the pressures in the health visiting service in relation to children. I wondered, is there an updated position?
Yes, so we've been successful. We've recruited 2 health. We had 4 vacancies. We've recruited 2 health visitors. One has just started a week ago. One is due to start at the end of August. We've successfully moved in collaboration with the commissioners. So because of our difficulty recruiting in the UK for health visitors, we can't train on Ireland. There is a real shortage of health visiting school nursing and qualified district nurses in the UK currently. So what we've done is we've taken on 2 development posts. with the view that the training will be, I think Julie May's been working with the ministers on providing training online from next year. So we've actually taken on 2 development posts, and they will be starting, one started already, one will be starting at the end of August. So the pressures are alleviating in health visiting, but it is a problem for qualified health visitors.
And I just wondered, in relation to that, and again we talked about the impact of COVID, particularly on new parents, and there were some pressures within that service. And are those sorts of pressures being relieved now as we move sort of out of the third wave in terms of people having face-to-face contact with health visitors again?
Yeah, so we're working with the Institute of Health Visiting, and obviously we've learned from some of our experiences in the first and second wave around virtual visits and what works and what really doesn't work. We're still a bit subject to the same pressures that you are with clinics in terms of space and capacity with social distancing. We're looking at alternative ways, so we're delivering some of our parenting programs virtually as well as face-to-face. And we're doing more of the parts of health visiting that's been successful. That said, we've got to be really mindful, and we have sort of gone back and retrospectively checked that everybody's had 2 visits in the first year. Because as we're aware, across children's services, there have been more pressures with safeguarding. I think it's been more families that were on the cusp of COVID which haven't now coped through COVID. So I think I would echo Hillary's view that maternity's got quite busy in this first 6 months of the year, but also that combined with families that were perhaps on the cusp of COVID that now have not coped as well. And so what we've seen is we delivered a Pediatric program for health visiting. What we've seen is more families moving up to that enhanced level, so that universal plus and that partnership plus level, which actually does put pressure on the service in a different way even if you are fully staffed, because you suddenly end up with lots more families requiring a lot more intervention.
Any other questions? Going to come to Fiona now. Would you like to tell us Brighter Futures, their recent work?
Well, Brighter Futures continue to be extremely busy. So when I spoke last time when I came, we were hoping we weren't going to have to start a waiting list, but we have for the first time in Brighter Futures history, we've had to start a waiting list, which commenced in June. At the moment, we've got 167 active families and 13 on the waiting list, and we are operating with a 1 out, 1 in basis, and it is moving quite quickly because it's the time of year that many of our families are moving into work, or the children are going to nursery. So it is a normal reduction in families at this time, but we're still incredibly high. And based on that, we continue to operate with a higher number of programs, and throughout the summer holidays, we are offering many more programs than we normally do. We're offering, for example, mindfulness, massage, relaxation programs, child development programs, respite, creche for families that need that, one-to-ones and dad's club. So that's a significant increase in what we would normally offer, which is a lot down to the kindness and generosity of our team, who are putting in extra hours, and some of our term time team are working hours throughout the summer as well, to make sure we can cover it because the need is there. So that's ongoing, and we're reviewing our groups for the September, and they're all already full. So the demand is huge at the moment. Over 50% of our referrals come through from family nursing. So the girls that are in there, they recognise the needs of the families and refer these families to us. And we've also got a big increase in self-referrals, which I think is a lot down to raising the profile, and people know that we're there and just feel more confident to walk through the door, because they want the support at that time, and they know they'll get a key worker straight away to tailor programs around their needs, and it's entirely their choice what they access, as long as we've got availability for it. One of the high areas of focus that we've been working on for the last 3 months, well, for the last 6 months really, has been the communication difficulties with children. It has linked to speech and language and the challenges that they've been facing. And we use a welcome screening programme, and there's been a significant increase in the children that have needed support for their communication issues and communication development. And our Time to Talk programme, it's especially tailored, it's small group support for the children with their parents, so that they can then take that learning into the home and work on those areas of need with the families. And that's almost taken on a whole life of its own. It was a small strand of our Growing Together Child Development programme, but we're looking at September now as that almost being a standalone programme that we're going to have to run because of the increased level of need. So that's really a big area for us. And I think that's it on Brighter Futures.
Thank you. It's really impressive to see how you are meeting need, but yeah, it's disheartening to know that you had to introduce a waiting list, isn't it? Still that unmet need, but your efforts are really sterling. Good to see. Any questions or comments? Caroline?
Do you think that the communication issues are directly kind of to do with COVID and social isolation?
Definitely, yeah. I think the effect that COVID had on the speech and language service links to our families, because if the service wasn't accessible when the children needed it, then the only development that they're going to go is going to go in a negative direction for them. So we had to really input a much higher level of service in that area. And it is getting better, speech and language is getting better, but it was really trying to bridge that gap at the time, because it was just a huge crash, wasn't it? And the children needed it, and they were in their homes, so they weren't socialising either.
I've got a grandson who was, I would call him COVID baby. I think Rose, you've got, you have one as well. The impact in terms of getting nothing from health visitors. No, this is in the UK, I don't, but Rebecca had nobody, and it's like, it was very difficult to kind of navigate your way around that, to then kind of even pick up if there was anything kind of to pick up, because you were just by yourself as a mum, new mum, with an intellectual grandmother in Jersey.
I think that's where it's different here, because we carried on visiting for high level need. So the Institute just sort of recommended not visiting.
Yeah.
We went virtual from university, we did it for high level need, and I think I'm pleased that we did.
Absolutely.
Families that really need that support. So interestingly, those universal families that were just on the cusp of farm support now need support. It's been quite an interesting process.
And it is playing catch up now, isn't it, with things like communication and.
But I think, Bronwyn, that's where your team came in with us, because you were working with those higher level of need and recognised the needs and then directed them to us. So thank you.
Yeah. Thanks, Fiona. Just as Gail's introduced my grandson, just to say that he was born in Jersey, so I speak from personal experience about the fantastic services that both of your services have provided. I know there is always more people that want them, but certainly around the general community, the feedback for the support for Brighter Futures, particularly in the past year, has come through lots of different quarters, and it's so well received. And I think what you provide is fantastic for people of this island, so just thank you.
Thank you. I will feed back to the team. Thank you.
And I think that's exactly what I was going to say. I think that Brighter Futures is such an amazing gateway, early intervention service for the JCM. I really do. I think your organisation punches so far above its weight around the intervention and prevention agenda, and perhaps we in government don't afford enough credit to it. actually around what you can do and how you can support our services and indeed prevent avoidance of our services. There is a huge piece of work, I think, which I know we've talked about with Ruth, around the whole Brighter Futures agenda. Really, really powerful. Thank you. Okay, any more questions for Ruth? So Gail, could I ask you to update us around the hospice?
Yes, I am in a moment going to introduce you to Mike Parkman, our new CEO, but I just thought I would give you a little update on what's happening with me now. I am moving into a role still within hospice, but very much looking externally about how we can support palliative care services across the island, both in the community and the hospital, and kind of integrate them together in line with JCM. So very much working with my buds to my right and HCS as well, to kind of really avoid duplication. This is all, we cannot afford to be wasteful. Certainly as a charity we can't, but we need to get this right for patients and their families. I think from our perspective, we come from that place of one chance to get it right, and I'm delighted, if I'm honest, to be working with Jo. I have faith in her as a professional, and I think where we're at now is we have developed an end-of-life partnership group. So looking at bringing all of the stakeholders within secondary care, primary care, and voluntary sector together, and we are looking initially at, probably myself will be writing a strategy, which will be ratified by yourselves, and then agreeing all the pathways. And I particularly have a thing about ED and ambulance. We've got to get that right, and if we do get it right, particularly with 24-hour nursing as well, there is a real opportunity here, and I'm very excited. So that's what I'm going to be doing. It's externally facing, but very much still that focus around actually I'm here for hospice and palliative care. So I am obviously handing the baton over to Mike, who I'm delighted to welcome to the island. And I'm going to let him introduce himself because I'm sick of my own voice, really. I will. What I intend to do, unless there is another thought around this, is kind of give reports to Mike to kind of feedback to the HCS board and kind of work with Jo around what we do from a strategic perspective. So, Mike.
Thank you. Chair, I hope we're okay for time, but I thought I'd very briefly just introduce myself and give you a few first impressions from my side, if that's okay.
Please
do. I'm Mike Polfreman. I'm only 3 weeks in. I was a banker originally, but let's not dwell on that. I have been in the voluntary sector for some 28 years, the last 10 of which as Chief Executive of Haven House Children's Hospice in North East London. I'm very excited to be here. I have heard an awful lot about the hospice before I came here. I heard a lot about its fabulous reputation within the local community and its hugely committed staff. And I have to say my first impressions are that it is every bit that, and I'm delighted with that. I have a number of areas I'm starting to get to grips with in terms of my focus, but perhaps just to pick out 4 in particular, 4 priority areas. One is most definitely working with and supporting Gail to my right on the work around the Jersey care model, which is clearly hugely important. But that's very much going to be Gail's lead on that. 2, long-term financial sustainability. Like any charity, we need to make sure we are sustainable for the long term. I want us to be looking very clearly at how we can maximise our fundraising and other income-generating opportunities, but also to ensure we can move towards an appropriate balance between other income and statutory income, and that certainly is something very much on my plans. We have, as I think people are aware, been looking at how we might extend our children's and young people's services, particularly potentially into a building. That's very much on the agenda. What I would also say is, if it is a building, then that building needs to be appropriate to the level of need, but also I'm very keen to ensure that we can work with you. Carol and I were talking about this the other day, to make sure that if there are other opportunities to use that to go a little bit, at least beyond the life-limited children and families who are our prime concern, then we want to try and take that opportunity to work with you on that. And the last thing I'll just say is collaboration. That's all about collaboration, but Rosemary and I know each other a little bit of old. We've both been big collaborators in previous roles, and we're certainly intending to collaborate both together and with other members of the voluntary sector. So watch this space. And I'll shut up at that point.
Oh, well done. Very valuable. Thank you. Yeah, it's heartened me to hear again how how community providers are working together, keen to work together, to work with HCS, so that healthcare is not delivered in silence. It's integrated throughout the island. It's great to hear all this interaction, and I think that's been an outcome of the board, and it's developed. The more we meet together as a board, it's great to hear. So I thank you all. It's really encouraging. Oh yes, I'm sorry. Any questions for the hospice team? No? Well, again, we welcome Mike to his role. Now, what have we got next on the agenda? It's one of our committee reports again. It's the People and Organisational Development Committee, and I'm going to ask Steve Graham, our Associate Director of People in HCS, to present the report, which is on page 43.
Thank you, Minister. Yes, this is the report of the work of the committee following a meeting on the 28th of July. And I'm pleased to say that we are on top of our action tracker. Over the last few months, a lot of work has been going on to get actions up to date and completed in a timely manner. And we now have all the current actions registered on the action tracker, which is a great improvement. And a lot of praise for that goes to Emma, who isn't here today, but Emma, the comments were proud on that. The committee has, over the last few months, started receiving updates from all care groups on their workforce elements of their performance reviews. And these are really important things for the pod committee to see in terms of how the care groups are looking at workforce and workforce issues. And to support that, they're using data from the workforce dashboard in an awful lot, in a greater way to understand workforce implications, which is great to see. And we had some quite robust conversations around the improvement plans they need in place to raise the level of uptake of My Conversation, My Goals, which is our appraisal system throughout the care groups. We viewed the latest stage 4 HR workforce dashboard, and from that we could see that there's an improving overall position across HCS in terms of vacancy rates and a low, quite stable turnover rate. The risk register was reviewed, and there's some conversation, again quite a robust conversation, about the need to update risks. Our workforce risks probably were overrated and may not have been updated as recently as they should have been. We had a report back from Annie Robson, who's leading on our Be Heard survey work on the action plan that she has in place throughout HCS in response to the survey, with focus groups running through August and September, and an increase in communications on outcomes now visible throughout HCS. We received a quarterly report on health and safety across HCS, which is a really valuable report in terms of incidents and workforce incidents, in terms of health and safety, and that was discussed in some detail. And we received a report from the Chief Nurse on the key worker accommodation that HCS needs to utilise, which is a key plank in terms of our retention strategy, making sure that staff that we bring in, if we need to, we've got somewhere to place them for their accommodation. The committee decided there was no issues to escalate to this board. However, we did identify one additional risk, which was in relation to the implementation of the junior doctor's contract, which is a legislative implication that we need to have resolved by the end of this year, and there is a robust plan and regular meetings in place to deliver on that as well.
Okay, thanks, Steve. I mean, we're always being asked and keen to know about the staffing levels and vacancy position. You say it's improving. Can you give us some data around that? And what's the reason for the improvement? What's happened? And what's good about this?
Yeah, I think it's multifaceted as you'd expect. So at the end of last month, we reported 199 vacancies at an establishment of 2,458, which is a vacancy rate of about 8%. That's in line with government overall, but it sits really well if you look across the board at the HCS, the NHS, where it varies between about 7.5% and over 10%. So we seem to be sitting in the right sort of place with regards to that. In terms of how that starts to look like, so if you look at the last 3 months, we had 40 people leave HCS, but we brought in 59, and that's a pattern that's replicated over the last 6 months. So we're bringing in more people than we're losing, which is why you start seeing an improving vacancy rate, because obviously that has a positive impact on your workforce. Our substantive numbers have increased month on month this year, a mixture of new people coming in, but also converting fixed term workers into substantive workers as well. So some of the issues we had in the workforce where we had a lot of people on fixed term contracts, which is unstable for them, moving them into substantive contracts gives us that higher substantive workforce as well. There are areas where there's higher than we want vacancies, so theatres is one that's floated quite regularly, and we know that, and so we are currently in discussion with NHS professionals about an innovative solution to that, utilising their UK bank to supply us with theatre nurses to on a fixed term contract basis, so that we can secure them. So that's something that we're looking at exploring. It's not an agreed deal, but it's something we will certainly consider as a way of trying to help us with those hard to fill vacancies. We've always got social media campaigns running. We had one running for radiographers, so we're trying different ways of doing things. I think one of the observations that I've explained several times when I first came here was our jobs are on a government website. Healthcare workers won't actually look at a government website, so we've got to create a buzz in a different arena to help them spot them and realise that there is a healthcare system here that is looking for people to come in and work with it. Our turnover rate is really good. We lost 184 employees over the last 12 months, which is a turnover rate of around 7%. If you take out retirements and dismissals, we're down to about 6% turnover. Now, as an HR professional, we start to worry when it's as low as that, because you need turnover to bring in fresh blood and fresh ideas. So, we're in a good place, we're in a pretty stable place. But as I say, we recognise there are areas where there are vacancies and we're working hard on that, but the overall picture sits well in what you look at the benchmarks.
Okay, thank you, that's encouraging. And we hear about the Be Heard survey as well. Can you give us a bit of detail on how staff are being asked to contribute and how we're trying to improve our connection and communication with staff?
Yeah, sure. So there's a colleague called Annie Roxon who's been brought in to lead on that, because it's quite an extensive piece of work across a complicated organisation. But we've got to the point where focus groups for people to comment on their departmental results are now running through August at the beginning of September to get their ideas on how we can respond to the things they told us in the survey. There's a communication platform now that's multifaceted. So there's an intranet page that's got the actual results published on it. It's got the data of the focus group. It's got an opportunity to go on it and highlight what people have seen in response to the survey. So we can start talking about those good stories and start getting a narrative out there that things are starting to change. There's a series of posters, a poster campaign that's now been released, a number of posters. So the first one just talks about the high level results, and then we'll go through a bit more of you said we did. The exec team has now established walkabouts. So as part of the Monday exec team, they'll go and visit wards and have conversations with staff about what's going on and what they're seeing and what they're hearing about Be Heard. The biggest challenge we face, I think, is that engagement piece, and recognising we can't just utilise email all the time. So in some areas we're asking team leaders to print out the communication and leave it in break rooms or leave it in places people can see it, so those people that don't access email also have access to this information. So just trying to connect with the workforce in as many ways as we can.
Right, thank you. And just lastly from me, you identified as a key issue the additional risk relating to the implementation of the junior doctors contract.
So,
say what that's about?
Yeah, sure. So the junior doctors come from the NHS. We sourced them through the deanery. There was a contract that was signed up with the NHS in around 2016 that is still to implement on Ireland. And it has implications in terms of terms and conditions to maintain comparity with the UK NHS. When we look at it, we can do it, and we've agreed to implement it. However, there's an impact on the rotas. So at the minute, we have a shortfall of staff to maintain the rotas as part of the contract. So again, we're looking through an organisation called Gateway Doctors to bring in additional resource to manage that. But there's obviously a risk there until we get that resolved. But the intention is to be resolved before the end of December, which is when we've agreed to have the contract implemented for that wave of junior doctors joining us.
Yeah, and Steve's highlighted it, some of the challenges. I think the other challenge around junior doctors contract is there's been a much greater emphasis on training of these doctors. At the moment, they do a significant part of their job is service delivery. This has been a trend over the last 20 years probably, where foundation doctors, formerly known as house officers nowadays, we need to provide them far more training and education, which means they'll do less service provision in the wards, which will have a knock-on effect to all other great doctors through to our fellows, our great doctors, and indeed consultants. So a larger piece of work around the whole medical workforce, and that we are currently looking at, and that we probably need to do even more urgently than we were before.
So are we planning to provide that education?
Oh yes,
Yeah.
I mean, as it is, there's a huge education programme for, but these doctors are very new out of university, and we can't put them in a position of being exposed to taking decisions beyond their capability. So we need to protect them, but even more than we have in the past. They're gradually turning from service provision to sort of almost full training posts, not full approaching supernumerary. They should be supernumerary at the moment in many areas, but that will increase. So we need to think about how we support those doctors. They add huge value to the hospital, to everything that we do. A lot of them will be local residents who've come back to do this piece of work before they go off and do their training, and then hopefully will be the GPs and senior doctors in the future. So we need to look after this group of doctors.
But will they still need to travel to the UK for their final year of education?
Well, I mean, these are doctors who've done their 5 years at university.
Yeah.
The first 2 years after qualifying for their foundation years, this is the doctors that we're talking about.
Right.
They will then go on to do either specialist training if they want to become hospital doctors, or get onto a training programme for general practice, which we have many of those doctors in Ireland, and they can oversee that as well.
So I know we've spoken sometimes about whether Jersey could ever provide that third year of specialist training, but that's not what you're talking about in education. Yeah.
So that's when you've done your 2 years as an FY doctor, you're doing your 3-year GP training programme, and as you're absolutely right, Minister, the first 2 years we can do on Ireland, but the third year currently they have to go back to the UK to do a year in practice, which would be my goal to get that on Ireland here. There's quite a lot of work we need to do for that, predominantly around training people to train them.
Yeah. I hope one day we could, because then if people could complete their education in Jersey, the hope is that they would stay in Jersey and we wouldn't have all these recruitment pressures.
Yeah.
But so no, okay. So this is their first 2 years as junior doctors. There's going to be greater educational input and change of rotas, which means that we're going to need more of them. So it's effectively, so that's the pressure, which will then mean we'll need more accommodation, and it just goes all the way through the system. Okay, right. So we understand. So you're telling us that all that has been planned: the educational side, the implementation of the contract, and the recruitment of extra in time. So we're not going to face a crisis where we suddenly don't have enough junior doctors to man the hospital.
Not that we're something
No.
going to see,
Okay, thank you. Are there questions, comments?
So can I just pose one question? I was at the Royal Free a couple of weeks ago, and it was interesting to hear, because I was my involvement here and what I did, I started asking quite a few of the doctors up there. The dropout rate, I gather, is high at the lower end. They come in after 3 years, they do 1 or 2 years, and they're dropping out, dare I say so, to banking, and finance. It was quite interesting. What they're saying is no different that we've got the problem here. And you take the Royal Free, and if you take Oxford as our other close hospital, they're all saying the same. So it's being able to maintain them and keep them, isn't it? And we've got to sort of make sure that we do that, which comes to the real question: do you have enough finance, Patrick, to be able to put that into place and maintain? Or I'm going to put the chairman on the spot as well. Are you saying you would like a bit more in there to be able to maintain that sort of situation?
If you're offering money,
that's what worries me. I've got a budget at the moment. But,
we would always appreciate more support, and I'm sure the chief nurse would say the same thing, around education and training of all our staff, really medical, nursing,
that seems to be the flag that's going up in most hospitals, is the training, the maintenance, and just hanging on to people now, because they're slipping out early on.
And we have a challenge around the Jersey care model, because it's predicated on expanding the roles and skill sets of people beyond doctors, and that will take training, and that will require investment as well.
We do get usually clerical, particularly postgraduate.
Yes.
Graduates got to remember, we do get quite a quite a substantial amount for that over, but I don't, incentivise for retention and keeping them on island. I'm not disagreeing.
I'm sure I heard we were doing this with more.
Just point it out.
I just hope the Treasury's not listening to that.
I think it's a really important thing, actually, because you've got to provide quality training.
Yes.
So we've got to find the people on island to train those doctors. So,
You're like me, Adrian. It doesn't matter what job you do. Training is all important, and the more you do, the better you become, the more you want to retain the individual. It's as simple as that, whether it's doctors, medics,
and that's
bankers,
traditionally, the junior doctors who've come through the system here have all gone back to the UK saying we're going to come back to Jersey, and actually quite a few of them do.
Yeah.
So whilst we will undoubtedly, I think for quite a while, have to let them go back, because you can't get all of your clinic experience on this island. If we've sent them away with a thought that they want to come back to us, that's a really good thing to do. So part of that planning is about having a good facility to educate them in, to have experts in their clinical fields who've got the knowledge and the time to deliver the training to them. It's very different medicine now from when Patrick and I graduated, where you learnt on the job. You can't do that anymore, and therefore we've got to invest significantly in that education and training, not just for doctors, for nurses, for all allied health professionals. Because if we don't, people will come here and love the island, but they won't want to stay.
Okay, challenges. All right.
Can I just clarify, Steve? You said about the recent theatre challenges around vacancies. My understanding is that out of an establishment of 86, there were 8 vacancies. So that the challenges were actually around sickness and maternity leave.
Sorry, theatres, yes.
Recognising, of course, that theatres are a difficult field to recruit to, and heartened to hear about the plans in place, but the recent challenges were not about vacancies.
Good about vacancies, no.
And I know there's been quite rightly concerns expressed outside of our hospital walls around a staffing crisis within the hospital. Yet your figures around turnaround and vacancies don't seem to support that assertion.
No, I think it's there are evidence in the numbers that there is no crisis in the hospital. There are a couple of hotspots, but nothing that would make you feel we are outside of where anyone else is at this point in terms of vacancies across HCS. And the fact we're bringing in more people than we're losing is a really positive sign, and if it continues at that rate, the vacancy rate will continue to drop. We've got 100, in the last 3 months, we've got 100 roles out to add, we've got 40 of them out to offer already. That kind of activity and that kind of sustained movement to bring people in will close those gaps.
And my understanding is that our ratio is 1 nurse to 6 patients, which, forgive me if I'm incorrect, the Royal College of Nursing has described as rich establishment.
Yes, yeah, so our, in the general hospital, our day ratios are 1 to 6.
Thank you.
Patients.
Thank you.
I mean, in terms of absence as well, around sickness absence, our average absence sickness days per employee is 3.3. In the government, it's 6 days per employee. So whilst we benchmark in terms of that, our COVID absence is lower than we see in the UK NHS. It's about 7.5% of our absence is COVID related in the NHS, it's 11%. Today we've got 15 people absent with COVID. So all of those things tend to suggest that there are people around to do the job. It's not massive gaps in the workforce.
So I think there's something that they're about us thinking harder about how we can address that erroneous perception that there is a crisis around staffing in the hospital, which the figures don't bear out.
Yeah.
And indeed, our staffing ratio compares very favourably with a 1 to 8 and 1 to 10 standard in the UK. So how can we assure our patients that that they can come into our hospital and receive really good treatment, and support our staff to continue to do that?
Yeah, you're right about changing the narrative. That is it, isn't it? The story is out there. We need to reinforce these numbers, which I do in the meetings on the staff side. Continually just telling people the numbers aren't saying what you're saying. When you look at our establishment and what our vacancy rate is and how many people we're bringing in against how many we're leaving, we're in a pretty healthy position. Certainly, since I started in September, I won't say it sounds to me, that was eventually since I started looking at this in September, you can see that month on month we bring in more people than we lose. That's a healthy position to be in.
It actually brings confidence really that you're actually triangulating the data rather than just kind of getting one bit of something and giving the narrative around that.
Yeah.
So it's not just around how many people you're recruiting, how many people are leaving. It's like what's your absenteeism factor. So all of it is a good news story actually, and maybe that's what you need to kind of, because you could do something, I might be constant, but you could do something around well-being, because actually you're throughout the COVID pandemic, the fact that you haven't lost a load of staff, the fact that you haven't got a load of people on long-term sick, you haven't got people kind of having that episodic, a couple of days I can't go anymore. All of that kind of is a story around your staff are actually doing really well in terms of their resilience.
Yeah.
I would suggest.
Yeah.
I just wanted to comment just on some of the points just for the benefit of the board, just in relation to homegrown. So we obviously get our staff from 3 different areas. We either return them to practice, we recruit into the island, or we grow our own. So part of our staff coming new into post in September for nursing will include 2 midwives who've graduated at the University of Chester. They'll go into posts which will take us slightly over our establishment in September. And then on the general side, we've got 9, again, university graduates that graduated this summer that will go into some of our vacant posts, certainly across the general hospital, with the exception of the couple of areas that Steve's mentioned. we have staff ready to come into post. We're just currently onboarding them. So a lot of the vacancies for the general hospital will be filled from a nursing point of view. I think as well it's really positive to see the interest in nursing as a career, and I think probably other professions are seeing it too. So we've got the biggest cohort we've had of adult students starting in September with a cohort of 19. Our cohorts are obviously sizable in terms of size for the island because we do train to employ, but that will give us a total of 54 nurses in training over the first, second and third years, which is probably the biggest number we've had for a long time, and that includes general adult nurses, which are the bulk of it, but we're also starting a mental health nurse training programme on the island in September thanks to government funding, and we've got 9 students starting on that programme this year again who will graduate in 3 years' time. In addition to those posts, we've got more student midwives, paediatric nurses, and we're working with the theatre team to increase their ODP workforce. So they already work at the University of Edge Hill, and we've got increased numbers of operating department practitioners, which again is a graduate programme, and they're starting in September. There'll be 3 and another 3 starting in January. So again, it will never totally replace or fill recruitment, and nor should it do, but it should provide a steady flow to support our workforce over the years and give local people an opportunity. So that's just a sort of general picture.
Thank you, Rose. Very helpful. Any other questions or comments? No. Thank you. Then we move on to item 9 on the agenda, which I'm pleased to see asked for this to be put on because I think it's important that people should be aware of how the hospital and health services have prepared themselves for any increase in COVID cases. And I'm perfectly assured that there is no need for concern in this area. But we want to make that as public as we can, tell everybody that we are prepared to meet any increase in cases. Figures are good at the moment, and we hope they will remain so. But I will pass over to Patrick for more detail.
Okay, sorry, just the technology. I was trying. Am I sharing the screen now? Or is that you? Okay, are you going to check the slides? Okay. So if you go on the first slide, please. So thank you, Minister. This presentation is to provide the board with more detail around our plan of maintaining our capacity during the third wave and hopefully to provide assurance. The plan, as always, sets out to maintain a safe, high-quality service for patients, including effective management of the infection, ensuring patients are seen in the right place at the right time, whilst maintaining privacy and dignity as much as we can. The plan takes account of the COVID modelling and its impact. It takes account of detailed demand capacity modelling around our business as usual, and it looks at the learning that we've seen during the first, second and indeed third wave. It considers the implementation of strategic plans, particularly around ambulatory care and retained COVID initiatives, and it aims to look at the early identification of risks and mitigations to capacity constraints. It considers our operational response and monitoring, and what I will cover in this presentation is the operational oversight, I think some of which we've already discussed within this meeting, the available bed capacity within the general hospital, oxygen resilience and staffing. So on a daily basis, these are the areas that are considered, amongst others, a little bit difficult to read, so I'll just cover some of them. We look at our daily bed status and capacity across HCS as a whole, our A&E activity, what's going on in the intensive care unit, length of stay, where we're seeing delayed discharges, so we maintain flow through the hospital, placement prevalence to care providers, social care assessments, We do look at daily COVID activity. We look at patient security across the whole system. We continue to monitor our PPE consumption across the whole system again, and very importantly in terms of managing COVID, our oxygen consumption. And as Steve, I think, has outlined, our daily understanding of what's going on with our staffing position. And of course we consider our staff well-being and safeguarding. In terms of the physical bed capacity itself, as of this morning, the 9th of August, the General Hospital has 207 beds open, and this morning there was a total of 143 patients occupying these beds, so an occupancy rate of 69%, which is extremely good, particularly when you look at that in the context of NHS hospitals. We are reviewing peak demand and validating that data, but it would suggest that on average the peak, during the peak there were around 15 patients with COVID in the hospital on general ward and 3 patients in intensive care. Though as of this morning, we had only 2 in intensive care and 3 patients in the ward, which is in line with falling numbers of COVID cases across the island. In terms of the estimated beds required for wave 3, we anticipated that most of these would require admission to a medical bed rather than to intensive care, but we're also able to use surgical beds capacity if any pressures developed. We've been working on an assumption from public health information that at most, at peak, 80 beds could be required, and that number is dependent on several other metrics. And if we reach that point, then we would implement the following plans. All available medical capacity would be prioritised for COVID and other emergency conditions requiring hospitalisation. We would stop elective surgical functions at the hospital, as we did in wave 1, and that would release around 40 beds. Emergency surgical and trauma care would be sustained again as we have in previous waves. We have the ability to discharge up to 20 patients from medical beds or medically fit for discharge and who are COVID free. These patients could be discharged into system-wide bed capacity through spot purchase arrangements, again as we did in the previous waves. We also have the ability to increase medical bed capacity by a further 35 surge beds, and we could use the 14 beds on the private patients area in order to deal with manage COVID. So this in total provides us with 109 surge beds across medical and surgical capacity at the General Hospital, though I would stress we have not had to use this capacity during wave 3 so far. This slide really demonstrates that the escalation would be in phases, and within phase 1 we would see the medical capacity, that's medical beds, being prioritised for COVID patients, and within this area there are the 55 beds that we've normally used for core work, and then 14 beds in the private wing as expansion. If we went beyond that, that would be phase 2, and we would seek to utilise the surgical capacity that I just described. This is how we come to the 109 beds, and again I would stress we have not gone beyond phase 1 during this most recent wave. In terms of our critical care capacity, we maintain the ability to expand up to 39 beds for ventilation. However, given the advances of COVID treatment, particularly vaccination, we anticipate that most inpatient bed requirements sit outside of the intensive care area. The other area that we have this time around, and we didn't have so much certainly wave 1 or wave 2, is we could seek mutual support from the South West UK Critical Care Network as additional capacity if we were filling our critical care capacity here on Ireland from NHS providers such as Southampton. We weren't able to do that in the first 2 waves due to the impact of COVID within the UK, but again we can see that the pressure on the NHS for COVID is also reducing. Worth highlighting, peak activity in wave for critical care services reached 5 hot patients. So down to 2 today. Next slide, please. In terms of oxygen resilience, that was one of the areas we were very concerned of coming into the first wave, but we maintained the ability to provide 900 litres per minute within the general hospital. We have other reserves beyond that. Throughout any of the waves, we consistently used less than 200 litres per minute, which shows that we have huge oxygen resilience. For an example, on a particular day in July, of 160 litres per minute were being used for surgical activity, not for medical activity at all. So, given that we could reduce that surgical activity, that provides us with even more resilience. Slide, please. Just going back to our workforce contingency, we're monitoring that on a daily basis. It's checked through the operational hub at the General Hospital, which happens every morning, and the hub will determine where staff are deployed across key areas within HCS services. Again, noting there are around 2,500 staff working for HCS, and the department has achieved exceptionally high levels of staff vaccination. The key areas in terms of focusing on staffing business continuity are within the General Hospital, bed-based and medical and surgical wards, within the specialist and critical care areas, and clinical support areas. We've also focused on single-handed practitioner services such as haematology, urology, and reading. We have over 656 registered nurses working with HCS, and we would seek to redeploy nurses from services that aren't providing urgent care to support inpatient units. I think we've got a slide up soon. Yeah. Sorry, that's the end of the presentation. Thank you.
Thank you, Patrick. Seems that there's excellent planning there and very good capacity to meet any emergency that we might yet face. Of course, the hope is that we are on the downward side of this third wave, and the island will continue, I believe, to see some COVID cases, but not in the surge that we might have anticipated in the past. Are there any questions for Patrick? Yes.
Just a comment. It was just in relation to the workforce piece. So that's 656 registered nurses doesn't include registered nurses who are working in jobs that aren't front facing. So we've actually got greater capacity. So we have nurses doing different sorts of roles that we would also pull in if need be, as we did in the previous wave, first wave.
That's fine. So even more resilient.
Yeah.
Caroline?
And I think it's an excellent piece of work. But I think what COVID has really shown us is the challenges perhaps that other sectors face, particularly primary care. And I think in conversations with primary care colleagues, I think they've been fairly battered by COVID, simply because they are individual businesses with different models, different pressures. They don't have the infrastructure that we are fortunate enough to have in government. And I know they've come out of it feeling quite bruised, but I think good, haven't they? And are in the process of taking stock of their own challenges, particularly around workforce, is my understanding.
Yeah, I think it's important. So I went back to the UK for 2 days a couple of weeks ago, and I was talking to some colleagues back there, and they were staggered with the fact that primary care has never shut its doors here, and there hasn't been a single day that primary care hasn't opened. It's been different. They've had hot and cold surgeries, and they've had telephone triaging, but they've never actually closed their businesses. Now, for a period of time, we supported them with a contract, which I think at the time was the right thing to do. But if you compare that to the experience in the UK, And for those of us that have got relatives in the UK, trying to access primary care in the UK at the moment is incredibly challenging. There are very few surgeries that actually will see you face to face. So I think we've done remarkably well, or they have done remarkably well to survive it. But I think the price that they've paid has been, for some of them, their own health, and certainly for all of them, the ability to run their businesses effectively. I think that any work that we start doing on resilience, we have to engage with them, because I think they are the group that need that support. So I'm very proud of the GPs and how they've worked through these very difficult times in COVID. We've had our moments with them, but they've continued to provide service, and that's really, really important.
Absolutely. I think that's the salient point. Full credit to them. You know, they have to continue to deliver primary care services to islanders. That's immense. I know, having elderly relatives myself in the UK, where there's no little access to primary care now, which you're seeing in the challenges around DD. So, but I do think there's something about the ongoing work that we do with primary care around supporting them around that resilience. Thank you.
Yeah, of course. Any other questions? Okay, so thank you for that presentation, Patrick. We next come on to item 10 on the agenda, committee report from the Quality and Risk Assurance Committee, page 45 in our bundle. And I'll pass over to Trevor if you wish to say a few words.
Yes, this committee's been a very successful committee in that successfully put together a revamp of its role. Since the last board meeting, we have met on 4 occasions in April, May, June and July. There is an extensive report which I'm trusting everyone has read, but Rose will be putting out some of the salient points in this report. And I'll hand over to Rose.
Thank you. As the Assistant Minister's suggested, because we've met 4 times, we have quite a broad agenda, as you can see. So my paper is a little bit longer than the others, so I won't go through every piece of it. I just want to pick out some of the key aspects. One of the things I just wanted to make the board aware of is that in relation to regulation of care, we've now got 17 areas registered, which were all the areas that required registration under the Jersey Care Commission, and 15 of those areas have now been inspected, with a further 2 expected imminently. Whilst we've had some recommendations overall, our teams in those services have done really well in terms of the work and the inspection reports. In relation to the work of the Women's and Children's Care Group, we mentioned maternity services, particularly in relation to the performance report earlier, and you'll see the updated detail in the report. We have, since we last met as a board, been through a scrutiny review of maternity services in Jersey, and that report is now available in the public domain. The team have been doing a lot of work and have been working really hard since last September on an improvement journey. And as we mentioned earlier, the C-section work, particularly in terms of our C-section rate in Jersey, I just think it's just important to note for the board's benefit that under NICE guidelines there is an option for women to opt into a C-section rate. However, the team are working hard to raise awareness, to put lots of measures in place to try and reduce our incidence of C-section rate in Jersey. Lots of different things that have been implemented, including a change to how the obstetricians work on labour ward and support women and work with the midwives. We've got different regimes in place now that offer a really enhanced multi-professional handover, and we're doing some specific work with theatres as well. And that's starting to have an impact on our C-section rates. So there was an audit undertaken last year, and that's just been repeated and presented to us as an executive team, and you can start to see the improvements, but it will take some time. The other big piece of work that Maternity's been doing is working with other partner organisations and particularly public health in relation to the sort of early messaging to women who are either thinking of starting a family or women who are in their first stages of pregnancy. And again, you may have heard in the media today that there's a focus on alcohol in pregnancy that's gone out today. And then the other thing to mention from the point of view of the board is around the maternity refurbishment work. So again, the physical environment has been a challenge for that team. We do have the funding now, and the refurbishment work is due to start imminently. The plans for communication around that are very well developed with the maternity team, and there will be availability for people to feedback real time, whether they are people using the unit, members of the public, or staff, while that work's going on, and there's a regular comms update that will be supporting that. Other areas just to cover is the Pediatric speech and language therapy. So we referenced this earlier in the board meeting. So we did have a paper that came to the April committee that we asked, following previous discussions and concerns raised here. And the paper was an extensive paper, but really set out the sort of drivers behind the increased weights for children. That basically the model of service delivery prior to COVID was very much a face-to-face model, which happened with educational and nursery settings, but also within the hospital environment. And one of the ways that they used to manage their caseload was also through group activities. Now obviously the face-to-face and the group activities had to cease during the initial phases of the COVID pandemic. So that significantly disrupted the way that they were able to deliver services. So they've done whatever they can do to be flexible and innovative during that time and provided additional information to parents in particular. But they went from a position of a 12-week wait for new referrals to a significant increase during 2020, which saw 12 weeks almost doubled to a 6-month wait. And then earlier this year, again, that increased further. Within their paper, they put forward a number of things that they would do to start to impact on that waiting list. And all of the things that they recommended as a mitigation have been implemented. And as of today, I can report that the referral rate, which had almost doubled, has started to reduce now in terms of the waiting times. They are still too high. So, for example, for the urgent cases, they were up to a 12-month wait as a significant impact. That's reduced to 7 months now, but with further plans to reduce it even further with some further investment. So they are going to bring a paper back to the September Risk and Assurance Committee that outlines their recovery plan with further recommendations, but we are starting to see movement there. The other thing is, in terms of the patient tracking list, they're not yet on track. So as the Director General referenced before, that does present some problems with our tracking of waiting lists when some are on electronic systems and some are on paper systems, but we will keep it on the risk register and we'll continue to monitor that. The other item, just again to reference out of the report, relates to health and safety. And the reason I've picked this area out particularly to focus on is this is an area that's sat on our risk register as a high risk for some period of time, and this really relates to our health and safety management systems, a fully integrated safe system of work. We've got real positive progress in this area, and have just outlined under each of the headings the significant improvements in the implementation of some changes to our practice that will start to see that risk be addressed. In terms of assurance around care delivery, we've restarted our formal assessments of our Jersey Nursing Assessment and Accreditation system this summer. Again, that was severely disrupted because of COVID, partly because we lost our lead for that to the vaccination programme, because she was seconded there to support workforce there, but also because the wards were significantly disrupted during that period as well. We have got seconded support into that team now, we've assessed all the surgery, we did a maternity assessment last week, and they'll continue to roll out, and there was nothing of requiring urgent action as a result of those unannounced visits that have recently happened. And then the other thing just to raise is Steve made reference to, in his report, about the risks on the pod risk register, particularly in relation to perhaps that they're not scored correctly and need a bit of challenge. We have agreed terms of reference for a risk management committee that will do that check and challenge, so that there is the richness of those discussions happens before the papers come to the various assurance committee, and that was approved at the last quality of risk assurance committee. We received the other committees updates from all the care groups as well in relation to their performance in relation to quality and risk, which I'm able to provide information on, but I didn't detail those in the report. I just pulled out some of the key areas, and I'm happy to take questions. Is that okay with you?
Yes, thank you, Rose. Any questions?
Rose, is there any facility for us to be able to do some cross-learning on the risk scoring, so that when we're all scoring, that we are all using the same parameters and the same, so they're comparable? Because I'm sure there will be some differences.
Yeah, I mean, absolutely. I mean, that would be really worthwhile. I mean, our work around risk has definitely been something we've been focusing on for the last couple of years, and we are getting to a place now where we're across our organisation, people are much more comfortable with being challenged around how they score their risks. And again, across government, they've introduced a new risk management system, which is really worthwhile doing it across the whole system. I've recently been involved in some of the SITREP meetings, which again look across the community in terms of the bed capacity, caseload capacity and staffing, and Joe chairs the bronze community meeting as well. But again, our understanding of risk can be quite different in those discussions, so that we could pick that up outside of here just to have a look at how we do that.
Rose, I'm really heartened to see that structured judgment reviewers are starting to find their feet within HCS. That's really useful to see that. The harm reviews that are happening around waiting lists, what is the trajectory for delivering that? So these are the reviews of patients who've been waiting.
So I don't think Patrick wants to come in, but at the last committee, that came to the last committee in July, there was a discussion which basically gave the care group leads, the AMDs in action to go back and have a look at their individual PTLs. I think the research that the Deputy Medical Director had done and put in his paper demonstrated that across the NHS, the sort of length of waits that you do the cut-off for your harm reviews, and I've put one example in there, is different for different specialties. So they were tasked to go away, do a little bit more work around their PTLs, and bring that back to the next quality and risk committee. I don't know, Patrick, was that, if you've got anything to add?
No, I think you summarised it, I think condition and just as well, so yeah, that was the next piece of work.
And have we provisioned that information to the care groups hearing around the number of patients waiting in excess of 48 weeks?
Yes, they have that, and they receive a weekly update in relation to their PTLs and the breakdown of where they are on their pathway. And we had at the last meeting, one of the AMPs came to go through the surgical specialty, so he had that discussion face to face.
So I know that the care group leads are focusing on this, but and I know we have it on our risk register, but it is a significant risk around potential harm for patients waiting. So is there plans to have a trajectory around delivery for the care groups?
Yes.
Yeah. Okay, and that will be monitored through exec reviews?
Yeah.
Great, thank you. Liz.
So what are we saying there? That we will set a maximum wait time for different services, no?
No, what we're saying is that the patients who have been on our waiting list, who may have been waiting for 48 weeks or more, and if they are, then those patients need to be reviewed. There needs to be a review of their notes, and if necessary, a physical review to ensure that those patients are not incurring harm whilst waiting for their procedure.
Absolutely. So, if we believe a patient is incurring harm, wouldn't we move them from routine to urgent? Say?
Absolutely.
Yeah.
Absolutely. So that's how we do good waiting list management. So as you know, our patient tracking list is a fairly recent innovation within HCS, and part of good patient PTL management is doing that regular harm review on your list of patients who've been waiting more than a designated time. And indeed, patients may change clinical priority and move from routine to urgent or to soon. So that's the work that's ongoing. Of course, the impacts of COVID has meant that we have more patients than we would wish for waiting longer than 48 weeks.
Yeah, of course. But we're working to bring that down.
But whilst we're doing that, we're ensuring that those patients waiting on that list aren't incurring harm.
Yeah, okay, understood. Any other questions? This is the report that deals with the speech and language therapy, particularly in the children's service. Rose has already spoken about that. Any other thoughts or questions? That's you talk there, Rose, about a business case submitted under COVID recovery funding. Was that supported?
Yes, it was.
Good, so we've got that.
And that's partly why we've seen an impact on those numbers. And
Excellent.
they have managed to bring it down quite quickly.
Excellent. Okay, so we're asked to note the report, and board members happy we note the report. Thank you. Then, the next item, pass over to the Director General. It's about amendments of terms of reference.
So colleagues will be delighted to know I'm not going to go through each document, but I'm also not going to make the assumptions, I know how busy colleagues are, that everyone's read them. What I'm going to do is ask the colleagues, we have our first committee meeting, which will be subject to these new refreshed terms of reference on the 25th of August. So could I ask that colleagues respond back to Danielle if they wish with any proposed changes, and if we don't hear from you, we will assume that silence is assent by the 25th. Would colleagues be happy with that? And this is our part of our process of reviewing our terms of reference annually in accordance with our governance structure. I'll also take the opportunity to inform the board that we have over the last week advertised for a Director of Quality and Safety, which is going to be a fantastic addition to our executive team. We are hoping to recruit a clinician who will lead for us on the whole quality, safety and governance agenda, and work really closely supporting the good work of the Medical Director and the Chief Nurse, and will help us around some of this as well.
Yeah, I think that's a key appointment. But Caroline, are there any substantive changes in the amended
Not
terms?
significant changes, it's just some of the changes around the membership that we agreed back in February of this year. So really it's just for board colleagues just to read through, and any suggestions or amendments or comments, if you could pass through to Danielle by the 25th of August, that would be great.
Okay, so board members can do that, please. Then item 12 is the finance report, and I'll pass over to Deputy Raymond.
A board meeting, is it so, as an accountant, that we end up with finance right at the end when everybody. So can we just take it as read and we'll all go? Yeah,
come on, it's your time to shine.
Thank you, sir.
The deputy's being generous today.
Can I introduce Michelle, obviously? I think if we just go through it, there's a few things that I'd like to say later on, and if there's any questions about any of the aspects of it, please don't hesitate to interrupt and ask any questions. But if I can hand over you to Michelle, we'll go from there.
Thank you.
And it is red, isn't it?
I would have thought, yes. And you did ask us to inject some humour. It's finance. I don't think I'm even going to try, but moving on to the key points, one thing I did want to highlight in the agenda, it states it's the report as of February 2021. It's actually June 2021 for the financial position. So I think that is...
Sorry, it was in the minutes, which just needs to be changed. We haven't noted it.
Oh, okay, thank you. We'll do that.
Right at the front. Just starting, I mean, the report is as of the 30th of June for this financial year. So it's the first 6 months of HCS's financial year. And if we take the year-to-date position first, year-to-date we're showing an overspend of 1.8 million. That includes COVID expenditure, the business as usual operational business case that was approved for funding back in May, so that we're just starting to see those costs coming through, the 3.9 million. That's within that position as well. The full year forecast for COVID related expenditure is circa 5.6 million at this point in time. That relates to 3.9 as I referred to for the operational business case, so that is getting us back to where we need to be in terms of normal business, but then we've got an additional 1.7 which was referred to on Rose's expenditure, that's coming through for recovery. So this is where we're really starting the patient waiting list coming down, but once we start getting, we can get people in post to drive that down for that side of it. I think the most important point for me for this financial year so far, we are anticipating to break even, which is a significant achievement this year. If you look at where we were last financial year, it's much better. We're much better in control of our finances. Efficiency savings remain a key feature. We're looking at circa 82% savings of the plan of 12.6 for this year. But I am hopeful that by the end of the year we will achieve a full 100%. Looking at July indicative, I'd say we'll probably saved about another 300k, which is fantastic. So we'll keep doing that each month, pushing on through. I think we will see a balanced position for HCS, which is really, really good. Continues to be challenging. We will have another 6.2 million efficiencies put on 2022. So I need to start working through that with all of the departments to see where we can make further savings. We're using ZBB, zero-based budgeting, as an approach and methodology that was undertaken externally. We've now tried to embed that as an organisation, really working through line by line each of the budgets. So we can see that transparency, linking in with HR to make sure staffing numbers are accurate, that we control establishment and control agency. So there's quite a lot of work to do, but it's looking really promising. So any questions on the financial position to June or any of the other information?
Any questions? Any others? Hugh?
All I just wanted to say, just to catch up, because I think some of the points that I would just to mention, just to let you know where we stand with Abbymore and some of the work that's been going on. Abbymore closure and relocation to Rosewood is now has been accepted, and that's going through the system. The proposed start on site May is roughly around April, May next year. And the proposed opening of the new unit in July 2023. We're also, the money's in the pot, shall I say, with regards to St Saviour's and the clinic, Benell and Rosewood situation. So there's plenty of good news. The one thing I wanted to say, having sat on this committee now for, let's say, a couple of years, I think sometimes, going over to you, sir, is that we never get across our positives. It's like the media will try and find a fault in something, so the waiting times are getting higher because we have less staff, but that's not the case. So they tend to use things, and when you consider that we have a hospital existing now, and it's like a house, unless you maintain it, it goes into disrepair. And sometimes I think, some of the people that I speak to outside, they never understand that we have to upgrade the theatres, and I've spoken to Patrick, that we have to close the theatres to upgrade them. But people don't think of that. It just seems to think it just happens. And it's somehow a shame that we can get those positive things out, because I think it's so essential. Because the other thing is, and Adrian knows this full well, that if it goes out as a positive way, it's so helpful for the staff as well. Whether you're the porter or whether you're the clinician, it doesn't matter. But you want to be part of something that is sounding successful. And I think that's why, from our perspective, from the finance perspective, is that we've got to try and make everything work and make sure that everybody out there knows that the staff are being looked after, the workforce is being looked after, and as I said, it doesn't matter whether you're a porter to top, but you've got to look after your staff. the budgets, and Michelle's been great with the budgets, and we've got some manipulation between them, because of COVID. But as I said, if we could get out there and just put the flag up, I think it will help the staff and everybody generally. But just an opportunity for me to say so, that we've still got to keep the hospital going. You know, dare I say it, we Jersey Care model, the new hospital, but that's a separate issue. People have got to understand we have a hospital out there, we have 100,000 population, and we've got to maintain that building.
Sure, thank you for that. That's really excellent to hear that. And this is about being transparent with all our data, helping people to understand, and that's why today we're publishing the integrated performance report. That's HCS, that's our position at the moment, that we see our pressures, but it'll help people understand how we are dealing with them. Because it's not an easy life, trying to manage a health service, but there's good work going on, and excellent people working in HCS. And I want to thank everybody for all the efforts they've been putting in to improve health care in the island. That's not just in HCS, but in all our partner organisations. Thank you. So that brings us to the end of our meeting, except just to say, is there any other essential business that anyone needs to raise? Any other business? No? Okay. Well, our next quarterly meeting is on the 8th of November, and I look forward to meeting everyone again then. We've talked about doing some work in between, so we look forward to that happening. And thank you very much for your attendance, everyone. Can I just say this is the last board meeting for Bronwyn and for Gail, who've been stalwarts, and we thank you very much for all you've contributed to board over many meetings, and we wish you well for all your plans for the future. Thank you. Okay, and that brings us to an end.